In the late 1800s, a slow disaster unfolded inside hospitals and asylums. Neurosyphilis, a late stage of syphilis, attacked the brain and spinal cord after years of seeming quiet. People who once held jobs and families began to change in ways no one could ignore. Memory failed, judgment bent, mood swung hard. Then the body followed with tremors, weakness, and a growing loss of control. Doctors watched patients slide from confusion into psychosis and from unsteady walking into paralysis. Many could no longer speak clearly. Some could not recognize familiar faces. These were not brief episodes that passed. The illness moved in one direction, and it moved steadily. Asylums filled with men and women who did not fit older categories of madness, because their decline looked physical as much as it looked mental. Medicine offered almost nothing that worked. Treatments existed, but they did not reliably stop the disease, and they often hurt as much as they helped. Care became mostly supervision. Prevent injury, manage agitation, wait for the next loss of function. Families ran out of options, and institutions ran out of space. Neurosyphilis became a sentence measured in years, ending in total disability and, for many, death. Doctors faced patients who seemed trapped in a one-way decline, and then something strange interrupted it. After a bout of high fever, sometimes from influenza, pneumonia, or another infection, certain psychiatric patients briefly spoke more clearly, moved with more control, or calmed after weeks of agitation. It did not last, and it did not happen to everyone. But it happened often enough that clinicians started to pay attention. At first, these changes looked like coincidences, the kind of odd turn that desperate wards produced all the time. Yet records piled up, a crisis of heat in the body sometimes lined up with a pause in mental collapse. The fever itself became the variable doctors could not ignore. If a disease of the brain and nerves resisted every drug and tonic, then maybe the body's own reaction to infection changed something the doctors could not reach. That idea carried a dangerous promise. Fever looked less like a random complication and more like a possible tool. Heat might have weakened whatever drove the illness, or it might have shifted the immune response in a way medicine could not mimic. No one could explain it cleanly, and there was no method yet, only a clue. Still, for doctors with nothing reliable to offer, even temporary improvement pointed in a new direction. Julius Wagner-Jauregg took the scattered reports of fever-linked improvement and treated them like a problem that could be engineered. He stopped seeing fever as a random accident and started framing it as a medical tool. If heat and inflammation sometimes pushed neurosyphilis patients into brief clarity, he asked a harder question. What if doctors produced that state on purpose, at the right time, under control? That shift sounded simple, but it changed everything. Wagner-Jauregg turned an observation into a strategy. An induced febrile illness, chosen deliberately, could be aimed at a disease that otherwise marched forward. The key word was controllable. He needed a fever that rose high enough to matter, yet followed a pattern doctors could track. And he needed an endpoint, a way to stop the illness before it killed the patient. So the plan became a balance of risk and design. He treated neurosyphilis as the larger threat and fever as a calculated shock to the body's system. It was not about comfort or symptom relief. It was about forcing the course of the disease to change. From that point on, the question was no longer whether fever helped. It was which infection could deliver it reliably and safely enough to repeat. World War I changed the scale of medical desperation. Hospitals stayed crowded, staff and supplies stayed strained, and hard cases piled up with nowhere else to go. For Wagner-Jauregg, this pressure did not just demand more beds, it demanded a decision. If fever had to be induced on purpose, then the illness used to create it mattered. The wrong choice meant chaos. The right one might finally turn an idea into a working tool. Many infections caused fever, but most stayed unpredictable. Some burned too hot, some lasted too long, and some killed without warning. Wagner-Jauregg needed a fever that came in a pattern he could anticipate, measure, and stop. Malaria fit that logic. It produced repeated spikes instead of one continuous blaze, giving doctors clear cycles to follow. Just as important, it had a known countermeasure. Quinine existed, and that meant the fever could, in theory, be switched off. That was the leap. Malaria as a controlled instrument, not a random calamity. It turned infection into something closer to a dosage. The plan depended on timing, letting the fever rise high enough, often enough, to challenge neurosyphilis, then cutting the malaria short before it caused permanent damage. It sounded brutally simple, and it carried obvious danger. But in wartime medicine, a dangerous method that could be managed started to look like the safest option available. He moved from theory to action. Instead of waiting for fever to appear by chance, he deliberately gave neurosyphilis patients malaria. It sounded backwards. Infect someone already deteriorating with another dangerous disease. But the goal stayed narrow and practical. Malaria brought repeated high fevers in a pattern doctors could track. If fever changed neurosyphilis, this method finally tested it under controlled conditions. The first inoculations were not treated as a single dramatic gamble. They were treated as a sequence watched day by day. Fever rose, broke, and returned again and again, like a metronome. That repeatability mattered. It turned an idea into something measurable. Patients either improved, stayed the same, or worsened, and each outcome could be linked to a known number of fever cycles rather than a vague one-time illness. Then came the second half of the plan, stopping the malaria on purpose. Once the fever run had done its work, he used quinine to bring the infection under control. That step changed everything. Malaria was no longer just a risk, it became a tool with an off switch. With inoculation followed by quinine, he built a protocol other doctors could repeat, compare, and scale beyond his own patients. Once the protocol settled into routine, doctors began to write up what they saw. Not miracles, not mass recoveries, but something that had almost never happened before. In early case reports, a noticeable share of patients stopped getting worse. Some regained speech, steadied their movements, or became clearer in their thinking. Others simply stabilized, and that alone counted as a win. For a disease that usually marched in one direction, any reversal felt shocking. Hospitals then tried to measure it. They compared admission records, discharge notes, and long ward stays that previously ended the same way. The numbers varied from place to place, but a pattern emerged. A significant minority improved, and more avoided rapid collapse. It did not work for everyone, and it arrived late for many. Still, it created a new category, patients who might leave the asylum alive. That changed how doctors talked about neurosyphilis. Word moved quickly through medical journals and professional networks. Clinics in different countries adopted the method, not because it sounded gentle, but because it sounded repeatable. Malaria could be induced, watched, and then stopped with quinine. That practical control made the idea travel. Soon, deliberate infection became the first widely used intervention for a condition that had been treated like a dead end. It spread on the strength of modest results and the desperation they answered. Once malaria therapy looked repeatable, hospitals treated it less like an experiment and more like a service. Doctors set aside dedicated malaria wards because patients needed close timing and tight supervision. Inoculation, fever cycles, nursing care, and then quinine all followed a planned sequence. The work demanded coordination. It also demanded containment. Malaria stopped being an accidental visitor in medicine. It became something clinics handled on purpose. With wider use came a new problem: consistency. Different mosquito bites and different blood samples produced different results. So clinics began using standardized strains passed from patient to patient under controlled rules meant to deliver predictable fever patterns. Records tracked which strain went where, how fast it took hold, and how patients reacted. This was a turning point. The treatment became organized enough to teach, repeat, and export as a recognized medical procedure. But the more routine it became, the risks became routine too. Some patients weakened under repeated fevers. Some suffered organ failure, severe anemia, or uncontrolled malaria. A number died. Doctors did not ignore these outcomes, but they weighed them against the usual end of neurosyphilis, relentless decline and certain death. That calculation hardened into policy. Complications and fatalities became accepted costs inside a system built to deliver a chance at recovery. By 1927, the idea of giving a patient malaria on purpose no longer sat at the edges of medicine. It sat in the center of it. That year, Julius Wagner-Jauregg received the Nobel Prize in Physiology or Medicine. The award did not just honor one man. It acted like a stamp of approval on the entire method. A practice once argued over as reckless now carried the world's highest medical prestige. The Nobel framing mattered. It turned a harsh trade-off into a success story. A planned infection, followed by a planned rescue, offered a chance where there had been almost none. Hospitals and doctors did not have to defend the approach in the same way anymore. They could point to international recognition and call it science, not improvisation. For many, the prize signaled that modern medicine had learned to use disease itself as a tool. But the celebration also changed the balance of power. When the top prize treated malaria inoculation as progress, hesitation looked like ignorance, not caution. The risks stayed real, yet the label shifted. Deaths and complications started to read as the cost of advancement. The Nobel moment locked the therapy into the mainstream and raised its status from a desperate measure to an accepted standard. From there, it spread with confidence that was hard to challenge. The more malaria therapy spread, the harder its costs became to ignore. Some patients never came back from the fevers. Others survived but came out weaker, confused or damaged by complications doctors could not fully predict. And in institutions, the line between treatment and control blurred. When someone lived behind locked doors, refusal carried little weight. What had been praised as a daring rescue began to look to some critics like sanctioned harm. Scrutiny shifted from results on paper to the way the treatment was used in real life. Consent mattered more than it once did, and hospitals faced uncomfortable questions. Who agreed and who simply complied? Who benefited and who paid the price? The same procedure that seemed acceptable in a desperate era now raised alarms when applied routinely to people with limited power. The therapy still helped some, but its moral certainty did not survive contact with these details. At the same time, medicine changed around it. New anti-infective tools appeared and began to offer doctors something malaria never did. A path that did not require deliberately causing another dangerous disease first. As these approaches spread, the old bargain looked less reasonable. If neurosyphilis could be challenged more directly, then the justification for induced malaria weakened fast. What once felt like the best option started to feel like an outdated risk. By the time modern medicine matured, malaria therapy sat in a different category. It looked less like a breakthrough and more like a warning label from an earlier age. Once antibiotics reliably treated the underlying infection, the logic of forcing a second dangerous illness into a patient collapsed. The benefit no longer outweighed the harm, and when a safer path existed, deliberate infection stopped looking bold. The change was not only medical, it was moral and legal. Modern standards demanded informed consent, clear alternatives, and protections for people with limited power to refuse. That mattered because malaria therapy had depended on institutions where patients often had little control. As oversight tightened, the old assumptions failed one by one. A treatment built on calculated risk now faced a new test: whether it respected choice. So malaria therapy ended up as a lesson in context. In the early asylum era, when neurosyphilis filled wards and nothing worked, intentional fever once resembled progress simply because it offered any chance at all. Later, with effective drugs and higher ethical barriers, the same act read as unacceptable. The science moved forward. The rules around patients changed. What once felt necessary became unthinkable.